This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. We're delighted you're with us today. And today is our last show. The last 3.25 years have been such a wonderful experience for Thomas and me. We've met such great people. You've been fantastic listeners. But we feel like, we've had a great run, and we're delighted that this last show is going to have some tremendous guests. And Thomas, our very first guest, is going to talk about a condition that's near and dear to you.
I'll tell you, the way this worked out is for our last show, my dad had about 8 years of Parkinson's disease, and that's ultimately what took his life. And we've talked about pneumonia, and that's a typical progression of Parkinson's. So we're going to talk about that first and a tribute and an honor and dedicate these two segments to my dad. His name was Tom Miller, and he was just a wonderful man. So we are going to listen now to Dr. Stephen Hurlbut, who is a neurologist at Texas Health Harris Methodist Hospital, talking about this topic that is way too familiar, Parkinson's disease.
Dr. Hurlbut, welcome to the show.
Thank you for having me.
I know many of our listeners probably think of celebrities like Michael J. Fox. But before we do a deep dive into this disease, can you explain how this neurological condition affects the body?
Yes, Parkinson's affects the body mainly in the way that we move. It's considered our landmark movement disorder. And the ways that we move that Parkinson's affects is the way we move our arms and legs, but also just our trunk and how we move about in our life. So the primary symptoms are a tremor. That's what most people think of with Parkinson's, but it's a special type of tremor. It's more at rest when the hands are just sitting in the lap. That's when the tremor's at its worst. People are stiffer that have Parkinson's. Doctors call that rigidity, but there's just a stiffness to their movement. There's a slowness to their movement. And often there's some balance issues. As it progresses, there could be some memory and language dysfunction, and people can start having some hallucinations, which is both from the disease and the medicines we use to treat. The hallucinations are usually like seeing children play in the yard. But in a nutshell, that's what Parkinson's is. It's a condition that affects the way people move.
To put this in perspective, do you know or have an approximation of how many individuals in the United States are living with this disease? And more specifically, here in North Texas?
Yes, there's over 1 million people in the U.S. that have Parkinson's. It's a worldwide disease, but here in the U.S., over 1 million. Supposedly 90,000 are diagnosed. New cases are diagnosed every year in the U.S. In Texas, it's estimated that 1,500 out of every 100,000 people in the state of Texas carry the diagnosis of Parkinson's. So in the Metroplex, that would be about 120,000 patients. So it's quite a lot.
Being a neurologist and having to treat patients, are there other neurological conditions that have similar symptoms to those of Parkinson's disease?
Yes, there are. There's a group of illnesses that we used to call Parkinson's plus illnesses, which means they have some of the symptoms of Parkinson's, but there's some other symptoms that go with it. These are not very common. Parkinson's is much more common, but some examples are there's one called multiple systems atrophy. There's one called progressive supranuclear palsy, which affects eye movement significantly. There's one called Scheidrager that really affects blood pressure. The one that's similar that is common is a condition that isn't really a movement disorder. It's called Lewy body dementia, and there is a lot of overlap with Lewy body dementia, and it's a common cause for memory loss.
So, when you think in terms of this disease, do we know what causes Parkinson's, and is it genetic in some cases?
So We really do not know what causes Parkinson's. We are still trying to answer that question. There is some genetic linkage in Parkinson's. Supposedly 15% of people that have Parkinson's have a genetic linkage to someone else in their family. So it's only 15%. It's not real high. We have identified 7 genes currently that we think put people at risk. And a few of those can be tested with the home kits. Most of those have to be tested by the doctor. The only thing we do know is that the younger people that develop Parkinson's, like Michael J. Fox, they are more likely to have some type of genetic link.
You know, when you have a patient that you're treating, and I know each patient is different, what are some of the forms of therapy and treatment that you can use to help treat this disease?
So once the diagnosis is made, the first step is usually medication options. The medicines we have for Parkinson's are very effective now. And the first line are usually medicines that in the medicine contains a chemical called dopamine. And dopamine is made in our body, and it's important for a lot of things. In Parkinson's patients, there is a lack of dopamine receptors in one part of the brain. And by giving the body more dopamine, the brain more dopamine, it allows the brain to work more normally. So the medicines we have a lot to do with regulating the dopamine. So we have medicines that have dopamine in them. We have medicines that make the dopamine that's already in the brain last longer. So the first line of treatment, usually with medications. For patients that the medicines just aren't working enough, say after several years of taking medications and the person's symptoms continue to progress, there are some surgical options that can be very helpful. Surgical options are not cures, unfortunately. We were hoping they would be, but that's not the way it's worked out. But they do really help with the symptoms of Parkinson's. It can reduce tremors. It can reduce stiffness that patients deal with. It kind of sets the clock back, and they often can take less medicine, but they usually can't get off medicine. So the surgeries are usually for patients where we just feel like we have to do something more aggressive. And all of this is on top of the things that we just know people need to be doing. And the people who just take good care of themselves, we're just constantly talking about the need to keep moving. That seems to be one of the most important things that a Parkinson patient can do for themselves, is to stay physically active. And then the diet, Mediterranean diet, is still what we recommend. And just taking care of their other health issues, the things that we really can control, like blood pressure and diabetes.
You know, over the 3 years of this show, we have heard this message over and over. Take good care of your health up front.
I agree completely. I think you're right. It starts with us taking care of ourselves, taking ownership. And then when these diseases occur that are not your fault, then we use the tools we have available to us to make that as good as we can. And it's in addition to the things you're doing for yourself. Those are the people who do best.
It's our last show on the human side of healthcare. We're listening to Dr. Stephen Hurlbut, neurologist at Texas Health Harris Methodist Hospital, on Parkinson's disease. My dad had it, and these 2 segments are dedicated to him. And the treatment today is far more hopeful than it was back then. Dr. Hurlbut tells us about it next.
This pre-recorded program is paid for by the Dallas-Fort Worth Hospital Council.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back to our final show on the human side of healthcare. We are wrapping things up talking with Dr. Stephen Hurlbut, neurologist at Texas Health Harris Methodist Hospital and also part of neurology specialists in Bedford. My dad had Parkinson's, so we're dedicating this segment to him, Thomas J. Miller. Dr. Hurlbut, let's talk about the anatomy. What's going on in our body with Parkinson's?
Okay, so in Parkinson's, we think we know the part of the brain that is mostly affected by Parkinson's, and it's a part of the brain called the substantia nigra, and that part of the brain has a lot to do. It's a very small piece of the brain, but it has a lot to do as a gatekeeper on managing the movements that people do. And there's a part of our brain that decides to make movements, and then there's other parts of the brain that make it happen. And the substantia nigra kind of connects those areas. That seems to be the area where the dopamine is lacking the most, and the part of the brain that is just not functioning well and causing the disease. So if you say, well, where is a person sick that has Parkinson's? We think it's right there. That's the main area where there's a problem. The whole brain is affected to some extent, but that is the main area. And you see the symptoms in the body. And so the disease is actually a disease of the brain, and that's why neurologists treat it. But the symptoms are mostly symptoms that occur in the body. So it can cause the weakness, the tightness, and the tremors.
And when my dad was diagnosed, my mom didn't want to believe it.
Yes.
She said, "No, it's Parkinsonism," and that is a term. And so, what's the difference?
So the difference is Parkinsonism is a condition where the person has Parkinson's symptoms, but it may not actually be due to the disease. Certain medications that we give patients can sometimes create some of the symptoms of Parkinson's. Sometimes exposure, certain chemicals people can be exposed to can, once again, cause the symptoms of Parkinson's, but we don't actually call it the disease. And so it's called Parkinsonism.
Now, Dad didn't have the tremors. He started slumping, and that's how we first started to notice it. So for people who don't have the tremors, what's the difference there, do you think?
It's not unusual, especially when people are older and they start developing Parkinson's, that they will have some but not all of the symptoms. The lack of tremor is not common. Most people with Parkinson's eventually, if they don't have it in the beginning, will eventually have the tremor. But I have patients who never have the tremor. My younger patients, like the Michael J. Fox, is in their 30s or 40s. That's a smaller group. They're the ones that may have more of a genetic link, and they are more commonly to have all of the symptoms we've been talking about. So sometimes people just don't have all of the symptoms.
Michael J. Fox was diagnosed with this years ago. I don't even know how many. I didn't go back and look up, but Dad lived 8 years with it, at least after the diagnosis. So How long now? And then you talked about all these new treatments. So what is somebody looking like today that gets a Parkinson's diagnosis?
So the prognosis is so much better than it used to be. And I've been a doctor for right at 30 years. And so when I first became a doctor, what we had was so little. And I've gotten to see all of these advancements come during my career. When we first started, we would typically tell people 5 to 7 years is probably going to be the life expectancy. Now we don't talk that way when we make a diagnosis of Parkinson's. There's not a clear endpoint. It has a lot to do with how they respond to treatment, and how dedicated the person is to keeping other areas of their life healthy. So my patients who buy into the system, who try to exercise regularly, they keep moving, they don't give in to just sitting, they keep moving, they treat their blood pressure issues or whatever else health-wise they're dealing with, and then they take the medicine to control as many of the symptoms as we control. They can live a very long time. So we don't really think of Parkinson's as a fatal disease the way we used to.
Tell you what, as somebody who lost someone that I loved very much, that is music to my ears for people and families who are going to face this going forward. Wow, that's awesome.
It is, and it means a lot. Like if you went through this with your dad, it means something to you. You know you're connected to this disease because of your dad, and it makes this disease that affects everybody. It affects the patient, affects everyone who loves the patient. So good news on diseases like this, it affects people, not just the person who has the disease.
Now, the treatment, does that reverse symptoms?
So the symptoms are treatable, I think would be the word I would use. Patients usually will see benefit from the treatment quickly. Within a few weeks, they'll notice some improvement in their symptoms. The slumping, the stiffness, the tremor, all of those symptoms respond to the different treatments we have. So they really do respond. Now, It is, just for an example, something like using a medication to treat high blood pressure. You can give a person with high blood pressure medicine, their blood pressure looks normal, but if you take away the blood pressure medicine, the blood pressure goes right back up. So it's not curing anything. It's just treating a symptom. And that is the way it is with the Parkinson's medicines. And as time goes on, you usually have to make adjustments in the medicine. It is common for patients with Parkinson's, ever so often, they and their doctor have to fiddle with their medicines. And that's what I tell my patients, is that we're never going to reach a place where we say, okay, this is it.
Yeah, that makes total sense. What a miracle. I am so glad to hear this. Now, the other part of this, at least from my own personal perspective, is you mentioned the genetic testing, and you were very clear about the numbers. It's not that much of a significance. However, curious minds sometimes like to be satisfied. Mm-hmm. So if I wanted to be aware of if one of those 7 is in my system, and one of those 7 genes you and Steve talked about, and I got the test, would there be anything I could do about it if I did have anyway?
So the answer right now is no. We don't know what to do with that information that you could use to prevent the Parkinson's from happening. And I think that's where we're struggling with a lot of the genetic information we have now, is that the information doesn't necessarily lead to a different treatment plan. And it doesn't, in the Parkinson's case, it's not a clear diagnosis that you're going to have Parkinson's. So no, sir, it doesn't really lead to us to be able to do something different. At some point, maybe it will.
You know, when it comes to new technology, advancements, as you look in your crystal ball, what do you see on the horizon in the treatment of Parkinson's disease?
We're very hopeful about the treatment of Parkinson's disease in the future. It's one of our biggest chronic neurologic illnesses, and we've had so much advancement in the treatment. The things that we're looking forward to are better understanding of how lifestyle and health issues can improve a person's condition. Are there supplements? Are there things people could do or not do physically or with their diet that may make a difference? We keep getting better medications. The medicines are targeting the brain better. They're allowing people to use less pills. That we have more and more long-acting medicines. Parkinson's has always been treated with patients taking multiple pills, and that's hard on a person. So these better, more targeted, long-acting medicines are helping. There are surgical options that are getting more refined, targeting the parts of the brain we think are causing the Parkinson's symptoms. And then we're hopeful for other things. You know, stem cell has been promised for many years for Parkinson's. Maybe it will come through as a valid treatment, other genetic testing and treatments. So there is a lot of research going on with Parkinson's, a lot of hope.
You know, you're a neurologist. To our listeners out there, what would be your best advice, whether they are affected by this disease or not? But maybe, as Thomas indicated, they have a family member. What's your advice?
My first piece of advice is don't be afraid to go to the doctor and get things checked out. If you have a tremor, most people with tremors don't have Parkinson's. There's a lot of things that can cause tremors. So just because you notice a tremor in your hands, that does not automatically mean you have Parkinson's. And a doctor can tell you that and can find that out. And if it is Parkinson's, there are treatments we have now, and people who get treated earlier seem to do better. Parkinson's disease is not the same thing as Alzheimer's disease, where unfortunately we still don't have a lot to offer patients treatment-wise for Alzheimer's. But with Parkinson's, we do. And then I think just don't forget to keep moving. Just try to stay active. Walking, if you're able to walk. Walking's plenty. You don't have to run a marathon. But just try to keep active physically and help your brain remember how to keep moving you around. That seems to be the people who do the best.
Dr. Stephen Hurlbut, thank you so much for your comments. Neurologist at Texas Health Harris Methodist Hospital and also part of neurology specialists in Bedford. There's a new focus in healthcare, and the DFW Hospital Council, who sponsors this show, is going to be leading new efforts in the Metroplex. We'll be back with an example of what that new focus is next.
This pre-recorded program is paid for by the Dallas-Fort Worth Hospital Council.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back to this third segment of our final show. You know, we're going to be shifting some of the Hospital Council's focus to this next topic: food disparities, food insecurity, an integral part of the inequities that happen in healthcare. We're going to be talking to Tauane Cruz, Director, Community Health Improvement in Dallas and Rockwall counties at Texas Health Resources. Welcome to the show.
Well, thank you so much for having me. It's a pleasure to be with you.
You know, for our listeners, they may not understand the concept of a food desert or a food swamp. Could you explain to them what we're talking about?
Happy to. So we'll start off with food deserts. Food deserts are residential areas with limited access to affordable and nutritious foods. So to determine if an area is a food desert, researchers usually assess the distance between someone's home and the supermarket. So the U.S. Department of Agriculture defines food deserts as a distance of more than 1 mile to the nearest supermarket. That's for urban areas, and then 10 miles for a rural area. And while improving access to supermarkets and grocery stores may increase the chances that an individual will be able to find healthier food, it doesn't necessarily mean that they will choose or can afford healthier options.
On a food swamp, is that defined any differently?
It's interesting that you ask about a food swamp because we really don't talk about food swamps enough, really. And they have a huge impact on the community. The food swamp is a little bit different from a food desert in that it's an area where food options are available, but they are usually high-calorie fast foods or junk foods as opposed to healthier food options. So there may be a grocery store available, but fast food joints far outnumber the healthier options. And some recent research published in the International Journal of Environmental Research and Public Health showed that food swamps actually have a higher impact on obesity in adults than the lack of access to a full-service grocery store.
You know, that's amazing. What a finding there, that a food swamp can actually affect obesity in a much more negative way. You know, we realize that there are food deserts, unfortunately, all across this nation. If you had to just look at North Texas, what seems to be the areas that have the most food deserts?
There are a number of areas throughout North Texas where there's limited or low access to food, but the trouble spots really are the locations where fresh food is scarce, and then the communities are also considered low income. On top of that, there's also the added burdens of limited access to transportation, which ultimately defines and determines where and whether you can go purchase food. And so you'll find food deserts in South and Southeast Fort Worth, throughout the eastern part of Irving, south of 183, extensively throughout South and Southern Dallas, in Grand Prairie, Central Denton County, even as far as eastern Plano and McKinney. But Southern Dallas really is by far the largest food desert.
With that you mentioned, Southern Dallas is the largest. What would you say, unfortunately, are factors that cause this?
Food deserts, they naturally arise from a growth in population that isn't accompanied by development. There's a lack of transportation for adequate public transit that makes it difficult as well for residents to reach options elsewhere. There's some additional factors related to businesses that fail because the community does not have sufficient financial resources to keep the grocery stores in business. There's some complementary factors as well, which are crime and fear, which usually lead to decreased interest from developers and may result in decaying businesses. So there's a number of factors that contribute to this growth of food deserts in specific areas. And I would guess that the increase in corner stores and dollar stores, while they help to provide access to staple items such as milk, butter, eggs, things of that nature, also increase the access to prepackaged foods as opposed to fresh foods. And these prepackaged foods tend to be loaded with fat, sodium, sugar, which we know are linked to diabetes, obesity, hypertension, and other chronic diseases that plague these very same communities. So overall, there's definitely a number of factors that contribute to the growth of food deserts.
So we've talked a lot about the problems, and the problems are extensive. But let's try to flip and be a little positive on some solutions. We know it's going to take a community buy-in. It's going to take support from different organizations. Can you elaborate a little bit on solutions that you see or would like to see to address these issues?
Sure. This is interesting because sometimes we think about the most visible solution, which is to put a grocery store where there isn't one. Unfortunately, we forget that ultimately healthy eating is a choice, right? So the same goes for community gardens. Sometimes we want to do something nice without considering the burden it may be to, for a local community to ensure the upkeep of the garden, or to be able to manage a community garden and provide the resources for water and food and everything else that's necessary to keep a garden going. So one of the things that at Texas Health we've learned over the years of working with local partners to deliver solutions that are specific and relevant to communities is that standalone efforts are much harder to keep alive. And so we have to have relationships and partnerships that matter and that are long lasting. And when it comes to local programs, there's really three questions that we ask ourselves. One, is it something that the community wants? Who did we bring around the table to help make those decisions? Two, is it a source of pride? Will people be motivated to participate and help it grow? And then three, are you in it for the long run? Making transformational change doesn't happen overnight, and we need to recognize that. Earlier, I mentioned that the corner stores are contributing to poor health outcomes because of access to unhealthy foods. And, one of the things that we've done at Texas Health Resources is really to try to think creatively outside of the box. So because of this situation with the corner stores, does it mean that the store should stop selling those foods? Not at all. In fact, it's a great opportunity for individuals to work with those grocery stores to introduce fresh and affordable foods, because those are locations where people are accustomed to frequenting. We have also taken the approach of integrating resources rather than creating new community-based touch points. We work with local organizations to address social determinants of health and providing direct and indirect support.
You're listening to The Human Side of Healthcare. This is our last episode, and we're talking with Tauane Cruz from Texas Health Resources about food insecurity in the Metroplex.
So one example that I wanted to share is the development of an in-school grocery store in partnership with Linda Tutt High School in Denton County. This is not Dallas County, but it's an example of something that we're thinking about expanding. It's actually a public-private partnership model that provides food and essentials such as toothpaste, shampoo, for students who may have limited resources at home. Interestingly, the grocery store is actually a complement to an overarching project that focuses on resiliency training and focuses on getting improving youth quality of life and teaching them to view life challenges as opportunities, and ultimately decreasing stress and anxiety, which is, behavioral health is an area of interest of ours. So we're currently exploring expansion of this model into other schools, and we're partnered with, specifically in Pleasant Grove, with A+ charter schools. We've identified 2 sites there and are looking for funding to advance this work in Pleasant Grove. Recently, one example of how this has already started moving and growing is that Albertson committed some financial support to establish one of these grocery stores within DeLay Middle School in Louisville. And so we look forward to opportunities to expand these partnerships further out into southern Dallas. The other example I wanted to share is that we're leveraging existing programs to provide wholesome support to families. Through an initiative called Yes Dallas, we're teaching youth about healthy meal options and healthy eating behaviors. We have live cooking demonstrations where youth and families can learn how to make healthy meals. We provide cooking utensils and equipment to low-income families who may not even be able to afford the simplest things like measuring cups and a good baking pan. And in partnership with the North Texas Food Bank, the YMCA, and Mark Cuban Heroes Basketball Center, we're exposing families to diverse nutrition education resources such as grilling, gardening, and other activities. And so this is a great example of how Texas Health is engaging with families while also partnering with local organizations to help these communities thrive. But we know that we can't do it alone, and we really don't want to. I think we all need to work together to create some unique solutions that are specific to these communities. One of the initiatives that Texas Health has undertaken for South Dallas specifically is called Well Together. And while we're focusing on reducing depression, we've really designed a community-centric program where folks can access counseling services within other community centers and at places like Brother Bill's Helping Hand in West Dallas, Salvation Army Pleasant Grove Corps in Southeast Dallas. They're able to connect with those services, but that also drives participation to those community centers who also provide a grocery store and different types of food distribution options, and so helping increase the overall impact. So these are the types of, I think, collaborations and initiatives that really help to address the specific needs of the community, but also work together with other community partners who have resources, and we're able to leverage those resources for the better good.
We've been talking with Tauane Cruz from Texas Health Resources about one of the key areas of healthcare focus going forward. When we come back, Steve is going to talk more about that as we wrap up the human side of healthcare next.
This pre-recorded program is paid for by the Dallas-Fort Worth Hospital Council.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back to the final segment of the human side of healthcare. You know, we mentioned previously that this has been a very enjoyable 3.25 years. You know, our Board of Trustees here at the Dallas-Fort Worth Hospital Council over 3 years ago asked that we do something to give back to the community, explain to the community how healthcare is delivered not just in the four walls of the hospitals, but also out in the community. And that's why we've tried to showcase over the past 3.25 years segments related, yes, to disease, illness, certainly talked about the pandemic, but also how we reach into the community. And we just had a guest on in segment 3 where Tauane talked about the needs of the community and how you collaborate and get the cooperation of community partners. So one of the things that our board is now asking us to do at the Hospital Council is to focus more on health equity. Now, as you know, we just heard about food insecurity, but income, education, transportation, race, cultural diversity, all enters into health equity. And we're going to do everything we can on a go-forward basis to drive improvement in healthcare outcomes, health equity, diversity, and inclusion. And we're going to strive to remove any barriers that compromise treatment, especially related to diversity, equity, inclusion in any hospital setting. We know we're going to need community members along this journey. We're going to have to integrate all aspects of DEI and health equity into the vision of where we go. We need to look at the culturally appropriate patient care, equitable, inclusive policies within our facilities, collect information and data to drive action, and ensure that we have diverse leadership, not only in the hospital, but in the governance, our boards of trustees, etc. And finally, and most importantly, have the community involved. Look at collaborative solutions so we can make North Texas a place where health equity is fair and treatment and outcomes are the very best. I know, Thomas, you've been in the media business for a number of years, but you also worked in healthcare. I think you know the importance of health equity and including everyone for good treatment. Would you agree?
Well, absolutely. And the resources that this is going to require to properly launch this, obviously, is going to be a main focus of the Hospital Council over the course of this year. And as you say, it's not a linear progress. It's not just food insecurity in South Dallas. This is something that we've had segments on this program where we've talked about high schools up in the northern suburbs that have food issues, kids that don't have dependable meals in the quote-unquote wealthier suburbs of town, and various programs that our hospitals were doing to address that.
You know, you're exactly right, Thomas. In fact, many of the schools, many of the universities and colleges have food banks. They actually have food banks within their institutions where students who many face food insecurity can have meals.
So when we think about the scope of this, it really can impact so many people in the Metroplex. So I'm glad to see this as a focus. There are so many areas that will be addressed here and a lot of community awareness. So it is something that as we shift away from doing this program every week and the resources that it took to do it, who would have ever thought that we would have planned this show in 2019 to begin in 2020, about 3 weeks before the World Health Organization declared a worldwide pandemic. It was amazing timing.
It absolutely was, and I'm very thankful because in many ways we were able to help educate and get the word out to people via this very program related to news and some of the things that we learned during the pandemic. I'm going to shift just a minute, Thomas, because we've kind of defined our future focus, but I'd be remiss if I didn't thank you for really the sweat equity, for lack of a better term, that you've put into this show. The amount of interviews, the edits, the excellent way that you presented this and the format that was needed, not only for podcast, but for KRLD. And I will have to give a shout out to our good friend, Paul Davis. Paul has stood by us. And for those of you that don't know Paul, he works for Odyssey at KRLD and some of their other affiliates, but he has stood by us throughout this entire journey. Would you agree, Thomas?
Oh, I'll tell you what, especially through the pandemic, KRLD has been so good to this program. And as we were trying to put messages out, for example, I think of the blood shortage that we had right after COVID hit, and all of the local blood banks were depleted. And we went on, and Paul initiated a PSA campaign of local spots, short spots. You may have heard some of those. And all of a sudden, the blood banks were calling us saying, stop, we're full, we're full. So you heard the message. And that's just one indication of how this station has been a partner with this show over the last 3.5 years.
You're so right, Thomas. A lot of what I would refer to as public service announcements, they ran on behalf of doing good things for the community, whether it be about giving updates on the pandemic, wearing a mask, blood shortages, as you say, just good information to help the health of the community. It's been a tremendous partnership, and we look forward to maybe one day in the future we can do something similar to this again.
Let's just do it when there's not a pandemic. How do you say if we're going to do it?
Yeah, it's probably a good idea. I think, Thomas, really, when people talk about strategic planning, so I wonder how many people did strategic plans in 2019, and then all of a sudden, a year later, they go, let's just throw that out the window.
I remember when we were putting the thing together and we had a group meeting, and I actually mentioned that if there were a health emergency in the Metroplex, that we had the ability through this platform to come down to the station and go live. And one of the people in the room kind of rebuffed that and said, "Oh, well, that won't happen." And boy, it's that old "don't ever say never," because you come back around. But I know you were on the media a lot in DFW during those times. And look, we did our very best under unrehearsed circumstances to convey in a long talk format some of the best resources that we could bring to the table from a community of very good doctors, and tried to give you the balanced perspective so that you could hear what their thoughts were in order to make good decisions for your health care around the pandemic. And whether you agree or don't agree with what we did, we definitely tried our very best.
No question about it. I think we all did our very best. And, there's one final group that I really want to thank, Thomas, and that's our listeners. What a great group of people that have listened to our shows, have given us feedback, sometimes positive, sometimes negative. But you know what? That's how you learn. But overall, kudos to the listeners, and thank you for making this 3.25 years so enjoyable.
Well, and there's one more, Steve, that I would like to add, and that is a big thanks to you. The Dallas-Fort Worth Hospital Council stands out nationwide for a very specific reason. And everything, one of my observations, falls top down. And you have been an amazing leader and driver and example for all of us of how to take very good care of our health and why we should. And I wish you and the council the very best going forward.
Thank you, Thomas. And to our listeners, thank you for joining and being with us today on this final program for the human side of healthcare. Be safe and be healthy.
The previous program is paid for by the Dallas-Fort Worth Hospital Council. All opinions or statements expressed on this program are solely those of the Dallas-Fort Worth Hospital Council or its guests and does not reflect the opinions or advice of KRLD or Odyssey.